Our next speaker will be Dr. Firas Alnidawi. He is a consultant neurologist in King Hamad University Hospital in Bahrain. He is member of the European Stroke Organization, Bahrain Neuroscience Association, national coordinator of Rescue and SITS International Stroke Registry, and he will talk about stroke, implementing stroke code. Please, Dr. Firas.
Thank you, Dr. Hani. First of all, it's an honor to be with you, sir, and you are a role model for many neurologists and strokeologists in the region regarding your efforts in implanting or establishing acute stroke treatment in Egypt and in the region. And I'll also thank for Dr. Suhail Al-Rukn and the organizing committee. Actually, the talk will be concentrating on one of four important updates from the last European Stroke Organization guidelines, and we will go through some of the cases throughout this talk. To start with, just a simple historian part about the stroke management. Stroke management with the randomized control trial start first with the NINS trial where the TPA first time approved for use for window from 0 to 3 hours, followed the window was extended after the European registry results to 4.5 hours. And we remain as a neurologist with one way of treating acute stroke, which is only pharmacological, till the release of the results of the Big Five, which is shown already by Dr. Talib, which is show that thrombectomy is effective manner to treat LV or large vessel occlusion stroke. And after that, until 2018, we remain only depending on our window, which is the time window, till the release of the DAWN and the Diffuse 3 trials, where the first time we are using another window, as Dr. Talib mentioned, the tissue window. Despite all this development in stroke treatment, we still stuck with some scenarios. Like in pharmacological treatment, we have only one agent, which is a TPA. And the exclusion criteria, specifically the use of NOACs, which is trendingly increasing, not only by cardiologists, by other specialties. And now it's prescribed for many conditions. Also, the wake-up stroke, and we know that as neurologists, one of the most important cause to exclude patients from acute treatment is the time window. Also, those patients presented beyond 4.5 hours, and they are not candidate or not planned for thrombolysis. For that reason, I go through this, the updated to 2021 European guidelines, and I will share with you these four important updates. Case one, this is a real case in our hospital. He's a 56-year-old male, non-case of hypertension. Last non-well was 12:30 p.m. Presented to our institution with left-sided weakness, dysarthria, and facial asymmetry. His NIH score was 8, and code stroke activated at 1:58 p.m. This is his CT, plain CT. And it showed that there is some hyperdensity sign in the MCA artery. This is the rapid software calculation of aspect score. And actually, we don't use it, but it's part of the software because sometimes it gives a false positive result regarding the calculation. But to stay with this case, the rapid software calculates through the stroke window that the aspect score is 6. Also, the software detects a large vessel occlusion in the mainly M2 part of the MCA. So in this patient, actually, it was one of the first time we used tenecteplase. And tenecteplase given to this patient. So the PICO, or what is the patient intervention comparator outcome, coming in ESO guideline, whether tenecteplase used in LVO stroke is better than regarding the functional outcome than the alteplase. So we know now that we have a new machine gun added to the previous gun, which is alteplase. To start with, we should know some facts about tenecteplase, that it is genetically engineered from alteplase, and it is higher fibrin affinity, greater resistance to the degrading enzyme, and it has long half-life. We give it only 1 bolus, and low effect on general hemostasis of the patient, and it's less cost. Actually, many studies previously, starting from 2013, many studies that try to address the answer for this question. Start with TAAIS study, which include 75 cases, patients divided into 3 groups, 0.5, one group 0.5 milligram alteplase, and the other 2 groups 0.1 and 0.25. And the study concluded that TNK was associated with significantly better reperfusion and the clinical outcome than alteplase. The second study, extended TNK 2018 by Dr. Bruce Campbell and his team, investigate TNK against in the dose of 0.25 against alteplase 0.9. And it concluded that TNK before thrombectomy was associated with higher incidence of reperfusion and a better functional outcome. The Extend 2 trial, TNK2, also by Bruce Campbell and his team, investigate 2 dosage of TNK 0.25 and 0.4, and they found that the higher dose have no significant improvement in cerebral reperfusion. 2 systemic meta-analysis. One of them published in 2019 showed that tenecteplase is non-inferior. And the last one published in 2021 in Stroke Journal. And it's concluded that acute ischemic stroke with LVO receiving intravenous thrombolysis with tenecteplase have significantly better outcome and recanalization than patients with alteplase. Return back to our patient. He received the TNK and was taken to the angio for thrombectomy. And I remember that it was so easy one, first pass by our intervention team. And days later, the patient was discharged home with NIH score 0. So what the guideline, what the ESO guideline and their answer to their question, to their PICO question, that they suggest intravenous thrombolysis with tenecteplase 0.25 over intravenous thrombolysis with alteplase 0.9 milligram per kg in patients with LVO and planned for thrombectomy. And actually, this is it's close to the recommendation of the American Heart Association, American Stroke Association, which give a reasonable, which they stated that it's reasonable to consider it. What's the future studies about our new gun, tenecteplase? We have twist study, tenecteplase in wake-up stroke, the timeless study, tenecteplase in LVO in extended window, the tempo 2, tenecteplase in those patients with LVO, but they are not planned for alteplase or EV or thrombectomy. The NORTEST, the Norwegian study, the NORTEST 2, which will include all the, including all the types of stroke, and finally the ATTEST 2, which include those less than 4.5, but let's check the superiority of tenecteplase to alteplase. And soon in the future, we will have the answer for many questions regarding this new agent. The second case, it's a usual scenario we are facing it as neurologists and dealing with stroke treatment. And actually this case, it's with an excellent outcome, but unanticipated mistake. So this is a 76-year-old male, past medical history, CAPG 10 years previously, last seen normal, 10:45 a.m. He fell down on his right side with a speech difficulty and right-sided weakness and NIH score of 9. Code stroke activated at 12 p.m. And this is his image, showing that the rapid software calculates the aspect score through the stroke window to 9. And also there is a left MCA in the M2 also, in the M2 part of the MCA occlusion. So through the phone, the patient was brought by ambulance. Through the phone, we contact the family. We spoke with his wife and his son, and we document the exclusion criteria, including anticoagulant. TPA started at 12:42 p.m. and and we contacted the intervention team, and they threw their way to the hospital. The NIH score dropped to 0. The patient improved totally at the end of TPA. And actually, we decide with the neurologist on call and the intervention radiologist on call decide not to proceed with a thrombectomy because the patient fully improved. The issue that when the family arrived, they brought the medication of the patient, and we found the patient is taking one of the NOACs, rivaroxaban, and his last dose was more than 24 hours, but less than 48 hours. We checked the coagulation profile before it was normal, and after TPA it was normal. The patient remained with no complication at all. His NIH score admitted to stroke unit, his NIH score stayed 0, and we repeated his CT angio and CT was showing no hemorrhagic transformation at all. And actually, sorry, I just get this image from the system. We don't have, I try to find the full reconstruction, but only you can see, you can appreciate here that the MCA is fully opened. So the PICO, again, the question in ESO guideline, in patients with acute ischemic stroke of less than 4.5 hour duration, who are using NOACs, does intravenous thrombolysis with alteplase lead to better functional outcome or not? And to start with, we should know some of the important facts. That NOACs nowadays, they are trending, they are increasingly used by cardiologists, by neurologists, even by pulmonologists. And among patients with NOAC having a stroke, approximately around 1/3 of them potentially eligible for intravenous thrombolysis. And in a study done in Europe, 70% of 5 million Europeans have non-valvular atrial fibrillation were on oral anticoagulant, with 40% of those 70% were on NOACs. In AF patients who are potentially eligible for intravenous thrombolysis, 1 in 4 patients had a prior anticoagulation treatment. So the ESO guideline, it's the same, it's repeated the same as the American guideline. They said, we suggest no intravenous thrombolysis. But if we go to the discussion that happened between the expert and their statement, we found the following. For patients with acute stroke treatment less than 4.5 hour duration, who used NOAC during the last 48 hours before stroke onset, and who have the anti-factor 10 activity less than 0.5 for those using factor 10 inhibitors, and thrombin time less than 60 seconds for direct thrombin inhibitor, dabigatran, 7 out of 9 members suggest intravenous thrombolysis with alteplase. And 8 out of 9 suggest the use of idarosozumab, which is the antidote in case that the patient taking dabigatran give the antidote and at the same time give intravenous thrombolysis. While the indexinate alpha use with intravenous thrombolysis, 9 of 9 suggest not to use suggest not to use it, and they were all of them against it. And actually, this is a very important topic. And as a neurologist, we face it maybe once or twice per week, and we are excluding patients from thrombolysis because of NOACs. Still, we don't have the answer, but there are many promising data emerging. And actually, I just refer you to read this paper, which is an open access paper in journal Neurology, Psychiatry, and Neurosurgery, which discussed this topic and put a very nice algorithm at the end of the paper, trying to answer this question and to help the neurologists and to help also the patients. Case 3 is actually not a real case. The scenario is real, but part of the scenario, I change it because we don't apply it now till now in our hospital. This is a 51-year-old female, non-case of diabetes, hypertension, dyslipidemia, presented with right-sided weakness and dysarthria on awakening. Actually, the real case is not on awakening. Presented with 1 hour after awakening with NIH score 5. In our hospital, we have, in addition to CT, CTA, and the CT perfusion, we have MRI available 24 hours in our code stroke if it's needed or indicated. So this is her diffusion wave, which shows that there is a restricted diffusion as shown here, so the stroke is appear on diffusion wave, but it's not appear on flare. And the PICO, which is the question by ESO guideline, in patients with acute ischemic stroke on awakening from sleep, unknown onset, does intravenous thrombolysis with alteplase lead to better functional outcome than no intravenous thrombolysis. And here we come to one of the important entity of stroke, which is wake-up stroke. We should know the following fact. The most frequent cause of excluding patients from thrombolysis is time window. 20% of strokes occur on awakening. And from those 20%, around more than 1/3 of them are eligible to thrombolysis, but we exclude them because of time window. The use of this concept, the diffusion weight flare mismatch, start by pre-flare, or investigated first by pre-flare study published in Lancet Neurology 2011. The investigator suggests that, or put the concept that, if there is a diffusion weight flare mismatch, to me that means that the lesion appear in diffusion weight and not appear in flare. This means that the lesion age is less, the stroke time is less than 4.5 hours. And they conclude that patients with acute lesion appear in diffusion weight, but not in flare image, are likely to be within the time window for which thrombolysis is safe and effective. After that, the wake-up stroke trial start to recruit patients, and the inclusion criteria was if the patient presented with on awakening or unknown time, disabling neurological deficit, age 18 to 18, and the treatment can be started within 4.5 hours of symptom recognition. The radiological criteria was the presence of mismatch, as I showed previously. And the main exclusion criteria was clinically, if there is a planning for endovascular treatment, thrombectomy, or if there is any other contraindication for thrombolysis rather than time window. The main exclusion criteria for image is if there is the MRI quality is poor, or if the lesion appear on flare, if the lesion is large, more than 1/3 of MCA, or more than 50% of ACA or PCA, or the lesion volume more than 100 ml. So what they use the same concept. If the lesion appear on diffusion weight, not appear on flare, they include. If the lesion appear on diffusion weight and at the same time appear on flare, they exclude. And after the result of this study and a meta-analysis, which is evaluation of unknown onset stroke, which is a systemic review and meta-analysis published in Lancet 2020, and it showed that the favorable outcome is significantly better with the alteplase group. And the investigator conclude that intravenous alteplase resulted in better functional outcome at 90 days rather than placebo or standard care. A net benefit was observed for all functional outcome despite an increased risk of symptomatic intracranial hemorrhage. After this study, the wake-up study, there was a subgroup analysis to the patients involved. The wake-up study recruited around more than 500, and the investigator in this paper published in JAMA Neurology 2019, they tried to figure out the lacunar infarction strokes or patients involved in the wake-up stroke, and they found by image-defined lacunar infarction 108. 55 of them were assigned actually in the study for alteplase, I mean in the wake-up study, and 53 on placebo. And they conclude that, the investigator conclude that while the wake-up trial was not powered to demonstrate the efficacy of treatment in subgroup of patients, the results indicate that the association of intravenous alteplase with functional outcome does not differ in patients with image-defined lacunar infarction compared with other types of stroke. So the ESO guideline now to 2020 and their answer to the PICO for patients with acute ischemic stroke and the recognition of the window lasting normal more than 4.5 hours and the recognition of symptoms less than 4.5 hours, and there is diffusion weight flare mismatch, they recommend thrombolysis with TPA. At the same time, if we don't have the MRI diffusion weight, we can even use the CT perfusion parameters, and also if we have a very good or a good penumbra and salvageable tissue, according to their recommendation, we can use intravenous thrombolysis using CTP and even MRP or diffusion weight or MRI flare. The fourth important update is in PICO. The PICO was in patients with ischemic stroke of 4.5 to 9 hours duration. We know that the onset exactly, it's more than 4.5 hours, and it's less than 9 hours. With a CT or MR core perfusion mismatch, does intravenous thrombolysis lead to better functional outcome than no intravenous thrombolysis? And there are many meta-analyses for a lot of studies done investigating this issue. One of the important meta-analyses is also again by Bruce Campbell and his team, and they found that the excellent functional outcome was significantly better with alteplase group rather than placebo group. And they conclude that patients with ischemic stroke with the window of 4.5 to 9 hours from stroke onset or wake-up stroke with salvageable brain tissue who were treated with alteplase achieved better functional outcome than did the placebo. And the rate of symptomatic intracerebral hemorrhage was higher with alteplase, but this increase did not negate the overall net benefit of thrombolysis. Another meta-analysis tried to answer this question and is published in Neurology 2019, reached approximately to the same conclusion of Bruce meta-analysis, and it reached that, it said that the complete recanalization and the functional improvement was higher in those patients with alteplase, despite the increase of risk of symptomatic ICH. So what the ESO guidelines state, they recommend use of intravenous thrombolysis if the surface of CT perfusion or MR perfusion mismatch is there, and some of the experts suggest only using the rapid software, and actually some of them they said there is no need to have the software 100%. So according to the software definition of the core, so it should be infarct core less than 70 ml, critically hypoperfused volume over infarct core volume more than 1.2, and mismatch volume more than 10. And actually they use definition which is used in the Bruce Campbell meta-analysis to select cases in the meta-analysis. So how the rapid software, this is a real picture for another patient. This is from our hospital, and as shown previously by Dr. Talib, that the software will collect the core by, which is here in CBF less than 30, it's 9 ml, and will collect also the penumbra by Tmax more than 6, and here it is 54 ml. And then we'll do the mismatch, and the mismatch ratio here is 6, and the mismatch volume is 45 ml. So according to the new guidelines, this patient, if he's not planned or not candidate for thrombectomy, presented with 4.5 hour to 9 hour, he may benefit from thrombolysis with alteplase. After all this, now we are confused which, all this development, which mode of image we should use. And this is a very nice paper written by Prof. Tomalak and published in Current Neurology Opinion 2019. So to guide the thrombolysis with alteplase, always we should do CT to exclude hemorrhage. If the window is 4.5 hour to 9 hour, we should divide tissue at risk by doing the penumbral image, whether CT perfusion or MR perfusion. If the onset unknown, we can use either the diffusion weight flare mismatch, as in wake-up stroke, or we can even use the penumbral image according to definitions that I showed previously in the ESO guideline. To guide endovascular treatment, as mentioned previously by Dr. Talib, always you should exclude hemorrhage first, identify there by CT, identify if there is any occlusion by CTA, exclude large infarction by calculating aspect, and if it is beyond 6 hour to 24 hour, we use either the clinical core mismatch or tissue at risk infarction, according to which study we depend whether diffuse 3 or don't. Also in this paper, very nice algorithm explaining what I said previously. And actually, after at the end, I want to just deliver this message, which is very important, that now we are changing from, in addition to time window, we have tissue window. But this message by in Lancet Neurology stated that diffuse 3, DAWN, Extend, ECAS, 4, Wake Up, and epithets trial, all of them implanted a new era in which we are extending from focus on time window to tissue window. The important thing, however, they say that time is a brain is still valid. So we should use this and this together. And my last message to you is stroke is a clinical diagnosis. And there is no mechanical substitute of a trained human intelligence. The truth is, it is the clinician business to know every diagnostic procedure and their proper application, but not to be a slave of any of them. So keep in mind, please, stroke is a clinical diagnosis. Thank you.